It's wonderful that patients are interested in their care. Obviously, medicine's one of those things where in the old days, you sit down, doctor would tell you what to do, you'd nod your head and go away, and that was that. Whereas in this day and age, there's lots of information available. Not all of it is correct, not all of it is relevant, but hopefully a forum like this will help people sift through what's relevant to them. It's nice to be able to talk to other people, not only in this country but overseas, as to what's happening, and see if you can find something that applies to you. So I haven't made my talk very highbrow, I just have kept it quite simple, mainly because Kelly's got a little bit more in terms of the research and the genetics, etc. But this is basically what's happened, probably what's happened to some of you. So I've kept it to choroidal melanoma. When we say ocular melanoma, obviously there is melanoma of the eyelid, which behaves a lot more like melanoma of the skin. There's melanoma of the conjunctiva, so conjunctivitis. So that part of the eye can also get melanoma, and that's a sun-related different condition to choroidal melanoma. Choroidal melanoma is part of the uveal tract. The uveal tract in the eye is the choroid, which is what provides the blood supply to the back of the eye. The ciliary body, which is what provides fluid, so that's what keeps your eye inflated. And the iris, which is what blocks the sun. But again, it's not related to UV exposure as far as we know. Why? That's the age-old question. The one thing we do know, it doesn't really happen very commonly in pigmented people. So I've seen one person of the pigmented race, Sri Lankan, with the choroidal melanoma. That is it. So melanocytes, or pigment, it's normal in me, it's not normal, I guess, in a Caucasian person. And for whatever reason, those pigmented cells, when they are in areas that they're not meant to be, take off, and that's where we get these cancers from. So what do we do? How do you diagnose it? Now this is probably a push that really hasn't been made in this country. Nowhere near enough noise has been made about what we need to do, because half the time this diagnosis is late, by the time you have symptoms, and not because people are going and getting checks. Now, cutaneous melanoma, there's lots of information. People know, slip, slop, slap, wear a hat, sunscreen, go to the dermatologist. There's GP clinics everywhere, get your skin checked. But we don't have the same message out there about getting your eyes checked. You don't go unless you have a problem, and most people don't have a problem until you hit 40. So there are recommendations out there, and it's more than just your vision having a problem. It's important from a familial point of view. You know, there are inherited diseases, many other things that can be found by people staring into your eyes. So it's worth us, you, together, getting that message across that it is important to get your eyes checked. You need a dilated exam. So for choroidal melanoma, yes, you can find things at the front of the eye, but you really need to have your pupils dilated. And that doesn't always happen when you go to the optometrist for several reasons. Time is probably the biggest one. But nowadays there is a machine called the Optos, and there'll be many more coming out, which does give a pretty detailed scan of the retina. It has its own limitations, so you can't just have that, but it will pick up many, many things as it becomes more and more widely available. Excuse me, it's in some optometrists' practice, but obviously it's a very expensive machine, so cost again is an issue. And then the symptoms. So if people do have symptoms, we try and encourage them to go and get checked, basically. And just, it's not something that anybody thinks of. I've got flashes and floaters, or I've got things floating around. Do I have cancer in my eye? I don't even know if that crosses anybody's mind. So everybody needs their eyes checked. Now this is a mnemonic, which is a variation. There's a very famous mnemonic which is used by the Shields group. This is basically exactly the same thing, but just easier to remember. And this is, I think, developed by Bill, really. So it's the spots, the D stands for something, and US, which is ultrasound. So we look for patient symptoms. We look at the position of the tumour. We look to see whether it's got orange pigment. The thickness, so greater than 2 millimetres. Is there subretinal fluid? Drusen, so that's what the D is. And drusen are degenerative changes that you see most commonly in macular degeneration, but they can be in any lesion that's been there for some time, so it's a good thing. And a halo, so we're looking for absence of those two. The ultrasound, so when we assess people, we always do our own ultrasound, and that's very useful in talking about the characteristics of lumps and bumps at the back of the eye. And what we've found is that each of these risk factors increases your risk by 3 times of having something bad. And more than 3 risk factors is most likely melanoma. Now, these are clinical signs based on thousands of patients. The biggest, most famous ocular melanoma group is at the Wills Eye Institute, and that's the Shields, my husband and wife team, who are powerhouses. I mean, this is what they've been doing for a living for forever and a day. And they have funding, they have fellows, they have researchers, they have volunteers, and they publish all day and every day. And so the figures, they're fantastic. They're really, they're true figures. And that's what we based a lot of our practice on. So what do we do? So if we decide you've got a melanoma in the eye, we screen. Now this is not done everywhere, but we found it to be useful for many things. And Kelly and Jane may touch on this, but having a melanoma, when we look at the history, there's often something else going on. So we're trying to work out why me? It's not son, it's not something I've done, it's probably not mum and dad, but maybe it's something in your makeup. So we screen the whole body with a whole body PET CT, and that's been useful in putting our mind at rest, putting the patient's mind at rest, that at that point in time, as far as we can tell, everything else looks fine. Let's deal with your eye. And then treat. So the treatment, there are so many different ways, and it's really tailored to where the melanoma is, what its size is, what your vision is, and you, really, the person sitting in front of us. So small melanomas, we break them up into small, medium, large. That's just based on a study, but it's also based on what treatment options we can offer. TTT laser is a thermal laser, so we cook it. We use heat to kill the melanoma, and it's not burning, it really is heat. So we try and use this heating laser to treat the deepest portion and slowly cook it to the top. If you use a laser, classic laser, a burning laser, all you'll do is burn the surface and leave all the melanoma cells underneath. PDT laser, now PDT is used in cutaneous melanoma, but it works really, really well in the eye in particular lesions, specifically melanomas that aren't brown. Not all melanomas in the eye are pigmented, and the non-pigmented ones respond fantastically well to PDT. The biggest case series of this is from Australia and New Zealand, so the group, so we all talk to each other in all of the capital cities, and we've put together a study based on this, and it works really, really well. In Brisbane now, we're looking at combined lasers. Not all of them are brown, not all of them are pale, some of them are mixed. So we're looking to see whether or not we can combine the 2 lasers and to see what effect that has. Now the success rate in terms of local control with laser is somewhere in the order of 80 to 90%, which is pretty good. In other words, laser alone, most of the time we can treat, if it fits the criteria, quite accurately and quite well within the eye, and get things under control. But it's really for small lesions, that not too thick. The good thing about that is it's very accurate. Really, we are shooting it, we can see exactly where we're placing the laser. We can preserve vision, which is important. It's not the end game, it's by no means the aim of the game, but it's a very pleasant benefit if we can treat the cancer and preserve your central vision. It doesn't really have any side effects, you don't feel unwell, and as I said, really, really accurate. The medium-sized melanomas, we can use laser, but it's often used as an adjunct, so after or before, to try and reduce how much radiation we use. Brachytherapy is radiation. Now, that's probably the most common form of treatment used worldwide. And in Queensland, we use iodine. Everywhere else in the country, we've moved to ruthenium, which is a more gentle, less strong and scarring radiation form, and we're in the midst of looking for funding to bring that to Queensland as well. We can use the combination, so once we've done radiation we can use laser on top, or vice versa. And obviously in some cases enucleation is used for medium melanoma. That's usually not led by us, that can be patient led, and obviously we respect the patient's decision. If you're sitting in front of me and you tell me, look, I want it gone, I can get rid of it. And that's not an unreasonable thing to want. It just doesn't change whatever's going to happen moving forward. So that's also been proven in big trials, that there's no difference between removing the eye and treating the eye, if you can successfully treat it, in terms of your life expectancy moving forward. And then obviously large melanomas. So large melanomas are usually hidden to begin with. They're very commonly hidden behind the iris, and by the time they cause symptoms or they're noticed, the size is so large that using any other local form, even though you can kill the melanoma, you'll probably do extensive damage to the eye. And that's a discussion that we've had with people before, where yes, we can use radiation. What are the chances of success? Well, they're fine, except you will have significant radiation side effects. And that's a reality. And so what we then end up with is somebody that ends up with 4 or 5 operations and then a painful eye that doesn't see, that we then have to remove. So when we can predict that and talk about the possibilities and the probabilities, we lean towards enucleation. And it's that's a difficult decision for us and for you, but it's something that in the scheme of things is still a very effective treatment in terms of local control. And then resection, local resection is something that we can do. There's a very, very small select group of tumours that we can cut out. The cutting out of a choroidal melanoma is not easy. It bleeds a lot. And again, you've got to weigh up the costs in terms of, not monetary terms, in terms of what that may entail for you. Technically, it's difficult. It's not an easy operation. It's been tried in places that don't have the right setup, and patients have died from the anaesthetic, which is an absolute disaster. So it's an option. It's out there. It's not done by many people in many centres, but you may read or hear something about somebody that's had their melanoma cut out. So prognosis. Now this, I guess, is the multi-million-dollar question. Local control, it's excellent. The numbers are really, really good. We're talking 80 to 90% from lasers, above 95% from brachytherapy. It's a very, very successful treatment. And really, we're not looking for much improvement in terms of how can we treat melanoma in the eye, because we're doing really, really well. We're looking for refinements all the time. Can we do it better? But the modalities that we have are very accurate. Probably the only one that's not available in Australia is proton beam, which is an external beam radiation. Now that, instead of us placing the radiation source on the back of the eye, X-rays are shot through the eye, but we still have to go and put markers around where the tumour is. So we'd go and put little markers around and say, this is where it is. You'd go and see the radiologist who takes photos and can localise it, and then they shoot it. Now that's 5 treatment doses over a week, and as I said, it's not available in Australia yet. Now, in the last budget, they said they were getting a proton machine in Adelaide, of all places, for whatever reason. And again, there's some very nice people in Adelaide, I'm James. And the machine itself, protons are used for all sorts of cancers, but the one for eyes has to be, specifically modified. So I'm not sure if that becomes available. I think that would be a win for Australian patients moving forward, because it's a nice modality for tumours that are too big to plaque, that in-between size before enucleation. It does work. So that's us and you and treating the melanoma in the eye, but the question is, what happens then? And we're talking about metastatic spread. Now that's, just as we heard before, melanoma is different to other cancers. It's not chop it out or treat it and that's the end of the story, because obviously must be melanoma cells floating around in bloodstream that we can't pick up on scans, and that also applies to choroidal melanoma. So as best as we can, we do the scan, but unfortunately we're not yet at Star Trek age where we can run the phone up and down your body and say, look, there's no cancer cells floating around. What we do know is that as we've moved forward and as more and more of the samples have been looked at, there are particular mutations within the tumours that put people at greater risk or not. Now, the tests to do that, they vary. There's many ways of doing it. We can look at the DNA of the tumour, we can look at the RNA of the tumour, and different laboratories in different countries do different assays. Again, cost comes into it. What we do here is probably one of the more simplistic forms. Again, as I said, this is completely unfunded, and the pathologists do it for us free of charge, effectively just bulk billing the test. I'm not even sure if does anyone know that he's doing that? But anyway, that gets done. In the States, there is an assay, and we've explored that with Nikki before, but that's $2,000 per test to get that done. There are caveats to all these tests. There's another test that can be done through the United Kingdom, where I did my fellowship, which is looking at the DNA of tumours. Again, they all talk about how accurate they are. When you actually break it down, they're about as accurate as each other when it comes to predicting what's going to happen, especially based on the tumour sizes. So big tumours, across all those tests, they're very similar. The statistics that they put out there are, you've got this percentage risk or you've got this percentage risk, and those percentages are roughly the same. In the smaller tumours, the newer tests are saying, look, we're quite accurate. The problem is, though, the smaller the tumour, if you take a sample, and the sample is not your whole eye. So in a big tumour, often it's an enucleation. So we've got the whole eye, we've got the whole tumour, we can look at it. In the smaller ones, we're taking biopsies with a needle. So that's a few cells. And we're talking things less than 3 millimetres that we insert a needle into and suck out a few cells. What they have proven is that if you take it from this section of the tumour, you can get one answer. And 25% of the time, if you take it from that part, you get a different answer. So which answer do you believe? That's the bit that we still don't know. Now, these tests, they are not done by national health institutes. They're done by people that make money from having the test done. So you have to read between the lines as to who's doing the test, who has a proprietary interest in the test, as to, how good is the test. And if you go to our oncology meetings, there's a bit of politics that goes on between the United Kingdom and the United States, and between Florida and wills, and etc., etc. And that's just the way of the world. But I think steps are being made in the right direction. We do know more and more, but we don't have the answer. And that's where I think the things that we're doing with QAMR, hopefully, with collaboration from all of the patients that come through the clinic, is hopefully helping to put, piece by piece, put together the jigsaw so that we can come up with an answer. And the aim is really to look for treatments for the disease if it does leave the eye. And that's really where we're struggling. From a medical point of view, nothing has changed in choroidal melanoma for a long time. None of the treatments, Keytruda is wonderful that it's available for cutaneous melanoma, but it hasn't made much difference to patients with choroidal melanoma. Not in any cohort anyway. There may be one or two patients here and there that respond to different things, but that's not something that has been proven. And that's what we're looking for. That's what everybody's looking for. Again, and I think Kelly may talk about this later on, we don't have a whole bunch of mutations. We don't know what kicks off the melanoma. We're growing these cells, and I've just met the gardener. Who sits there and tends them very, very carefully, but for whatever reason, sometimes they don't grow for a long, long period of time, and then all of a sudden they grow. And so why is that? That's not what a cancer does normally. Cancers grow and grow and grow and grow. But in the eye, for whatever reason, we don't know what makes that happen. We don't really know that answer yet, and that's what we're looking for. So that's why we're hoping that by talking to you, by you all talking to each other, all the research, that you'll be involved in our research as well, and we can hopefully collaborate with other people around the country and hopefully come up with some answers, hopefully have access to some trials. As you said, nobody really knows much about us or the disease. It's hard to get the general medical field interested. If you find an oncologist that's interested in people with cutaneous choroidal melanoma that's gone elsewhere, then, well, send them my number, because that in itself is something that we need. We need multidisciplinary care. We need an oncologist who's interested in not just cutaneous but choroidal melanoma, who talks to people in other countries, like hopefully you all are doing. And then with MPA, hopefully getting access to some of the drugs that are being trialled elsewhere, but certainly aren't being trialled here yet. So what we can do, though, it's limited, but I think it's worthwhile, is that we screen. And we will have the information as to, if you wanted to know what risk category your particular tumour was, that can be found out if there's been biopsy done. But regardless of that, because that's just a stratification, we encourage people to get liver screening. And that can be an ultrasound, and again, cost comes into it. Ultrasound has a rebate. But the best test is really an MRI of your liver, but it costs money, and there's no rebate for it, unfortunately. What it has shown, and this paper that's come out of France a couple of years ago, that if you do pick up something and it's removed early, your life expectancy doubles. Now, I'm not going to tell you what the numbers are, but it's double. Double's good. So that's why we screen, and that's what we're looking for, is a spot, single or double, small spots that can be surgically resected, no chemotherapy, which is an improvement on what else is out there at the moment. So that's what we're looking for. The research, as I said, early days, but we're hoping to kickstart. We're hoping to get a little bit more enthusiasm for other centres around the country, trying to get all of us out of the mentality that there's nothing that we can do, and we're trying to do something. So that's where we're up to.